Okay.
Okay, so today we
Uh,
will discuss
Dr.
about, yeah,
Arushi, let me introduce you. Welcome, Dr. Arushi. We are privileged to have her. She has done MS, FMRF from Santara Chennai, and FICO. She had got Maharashtra set from clinical exam rank of 1, and she has been a very interested in teaching and academics, and we have had her talk previously also, and now we'll be having this talk, which is very important, serious topography, which will be for both beginners and advanced users. I think Dr. Arushi, you can please start.
thank you, sir. Uh, we'll be starting on Sirius topography. This is how the machine looks. And so Sirius topography provides curvatural, pachymetric, elevation, and diopteric data over a 12 corneal diameter. Okay. Now, curvatural means the keratometric values. Pachymetry is the thickness. Elevation is the curvatural difference of that cornea with respect to a best fit sphere. And diopteric means the overall curvature of the anterior and the posterior cornea. Now, the advantage of Sirius is that it has both Placido and Scheimpflug camera. That means it takes measurements from both the methods. So the anterior surface, the data comes from the Placido as well as the Scheimpflug, and the posterior comes only from the Scheimpflug. The current model is Sirius Plus, which is approximately, yeah. So these are all the functions that we see in Sirius. You can have a topographer, there's a pupillographer to see the pupil size, lens densitometer to see the cataract, mebography is there, and tear film analysis is there. Today we'll be speaking about topography in detail. Now, this is how it comes. So first is the Scheimpflug image, as you can see on the right side. So this was similar in Pentacam, which I used to utilize a lot while I was doing a study on multiple ectasias in the same eye, which had PMD as well as keratoconus, or globus as well as keratoconus. So what you can do is you can actually rotate this image on the entire cornea, and you can get an idea as to how the anterior and the posterior curvature is changing. Then there is keratoscopy. This is the keratoscopic image, which is a Placido, which is based on Placido rings, and the regularity and is seen the irregularity, the crowding of rings, which will give you an idea of how the corneal surface is. Then comes the single map, multi-map, cataract summary, keratoconus summary, glaucoma summary, intrastromal rings, aberrometry. And after that, what we can also do is compare images of the right and left eye. What we can do is a keratoconus follow-up over of the same patient over various visits. So I would really encourage you all to actually sit on your topographers for at least few hours every week and get to know them, because it's very, very interesting. So the first thing that's most important that you see on the scan that you get is the quality of the scan, and that is given by the amount of coverage of the scan and the centration. Uh, then we come to see all the maps, which are all these different kinds of maps are available. This is how, so what we normally see is the printout that we get, but this is how we see it on the machine. This is the pachymetric map, and the pupil center coordinates can be seen here. In the same way, yeah, there is thinnest pachy and the coordinates can be seen here. And you go to the single map, the tangential maps, and you can see the K max here and the coordinates of that here. Okay. So now we come to the part that we need to see when we read a report of the topography. The first thing is horizontal visible iris diameter. It is utilized clinically for ICL. The gold standard is definitely digital caliper, but this is also used especially for surgeons who are not very comfortable in using the digital caliper. So to understand more, the green arrow is what we use for ICL. So it is from the clear corneal to the clear corneal limbus. Then we come to this, which is the pupil diameter. Then we come to the pupil coordinates. So the center of the pupil, as you can see, this is the ring, the 3 mm or 2 mm or 3.97 is, this is the pupil. And the center of that is the cross, and that's the pupil center. So the coordinates of that are in this form. R is equal to 0.14 at 354. Now, what does that mean? Supposing this is the left eye, then 354 will be somewhere here, and 0.4 mm means just a little bit towards. So that is how it can also come in the form of X and Y coordinates, but this is actually easier. So then we come to the thinnest location of the cornea, which is in this case 533. Thinnest location is important. Normally it should be near to CCT. More difference with CCT means there is some ectasia in the cornea. The difference between the thinnest pachy and CCT should not be more than 10 microns. Now, what is a thin cornea? Means that the CCT is less than 500 microns. Now, normally we wouldn't do LASIK in CCT less than 500 and PRK less than 470 microns. So every cornea that's less than 500, and specifically if there are something that you can see which is not correct on the posterior maps or something, then we would maybe label it as a thin cornea, and then see if you can do a LASIK or you have to go for a surface ablation. Also, CCT, very important thing to understand for every person who is seeing progression of a ketoconic patient. So if supposing the keratometry is increasing, but the pachymetry is same, it is very unlikely that there is a progression and you don't need to do a CXL. So very important that pachymetry is the most important thing that we see in progression. Okay. So the next is apex, that is the steepest point on the tangential curvatural maps. Now there's a question if CXL works in steep corneas, which is still a question. It's not, sometimes it works, sometimes it doesn't work that much, but in case the pachymetry allows a CXL, to please go ahead with it. Then there are other details like anterior chamber details, the CCT and the AC depth, and volumes, and other things. So now we come to the simulated keratometry, which is a complete keratometry of the anterior and the posterior surface of the central 3 mm cornea, and it assumes the ratio between the anterior and the posterior curvature. So simulated keratometry is simulated because it assumes. Below that, there is an average simulated keratometry, which is important, especially in refractive surgery, when we need to see how much the cornea is going to be finally steepening or flattening. Also, steep K and flat K are in K1, K2 are to be seen, because steep K more than 47.5 chances of buttonhole are more, and flat K more than 40 chances of free flap are more. Below that, you can see the anterior 3 mm, 5 mm, 7 mm, and posterior 3 mm, 5 mm, 7 mm keratometry readings. Now this keratometry you can see in the posterior, it is in the form of R1 and R2 actually. No, actually it's keratometric only, but it can also come in the form of R1 and R2, that means radius. So that's also one way of documenting a keratometry. This is the there are two types of curvatural maps. One is sagittal and one is tangential. Sagittal is relative to the axial surface, axial center of the surface, and tangential is it is by drawing circles tangential to that particular area. So in tangential curvatural maps, more localized elevations are better seen, and in sagittal, more of global things are better seen. Sirius utilizes more of tangential maps in its calculations. Yeah, so this is the reference body, which is the best body that fits the corneal surface. And as you can see, the part of the cornea that's above this best body is in the hot color because it is above. So that is what is elevation data. And this part, which is in the blue, this part of the cornea is below the reference body. So it is coming in the blue. So the center is hot and the periphery is cool. Now, best reference bodies could be sphere, could be toric, ellipsoid. So the difference is better are toric ellipsoids because they enhance the astigmatism, irregular astigmatism, whereas best fit sphere will enhance the regular astigmatism also. Okay, so if there is regular astigmatism, it is a symmetric hourglass pattern. For example, here we can see the different curvatural maps so with superior steepening, inferior steepening. This is irregular. This is a symmetric bow tie. This is a symmetric bow tie with skewed radial axis. Asymmetric bow tie with inferior steepening. Asymmetric with superior. Can anybody tell me from here that if we have a skewed axis of the curvatural maps, then what all can be there in the patient? What all are we looking at? Can anyone attempt this? Agar, yeah.
Giving more than 21 degrees, so we label it as a keratoconus suspect. So formaphrustic keratoconus can be present if its skewing is there, but other parameters are normal, or it may be a frank keratoconus.
Okay, very good. So what could be, so can it come in a normal patient? Can a skewed axis come in a normal patient if something
Yes,
is wrong?
skewing can be present, but the degrees of skewing might be less than 21 degrees if it is normal.
Supposing it is more than 21, can anything go wrong with the scan, the way the scan is taken?
Yes, definitely.
What can go
It's
wrong?
not being taken from the center. If it is taken at the periphery, patient looking at one side, then the scans might alter.
Yeah, so that's a very, so you need to check that also, repeat the scans. And another thing is angle kappa. Angle kappa is the angle between the visual axis and the pupillary axis, right? So even if the angle kappa is very huge, there might be a skewing of the axis. So that's also one thing that sometimes we need to see in hyperopic patients, because that's when the angle kappa is large. Yeah, this is angle kappa, extremely important thing. It can be seen from pentacam in Sirius. It is also there, but it is less accurate in Sirius. Especially important for refractive surgery and in multifocal IOLs. So what we normally do, where we normally put the IOLs and center the refractive surgery is on the pupillary axis, but the visual axis is slightly nasal to it. So this is the angle kappa. This is a normal angle kappa, where from the pupillary axis, the angle, this is a little bit nasal to it. And this is little bit, this is a large angle kappa. So when we, in case of a large angle kappa, if we do not decenter our ablation little bit nasal, then we might get a incomplete ablation, and we might have some number, especially in hyperopes post-op. This is also one of the reasons for a skewed axis. Okay, now we come to the indices specifically for Sirius topography. So the SIF and the SIB, which is the difference in the curvatural maps of the tangential curvatures, inferior minus the superior, in the front as well as the back. Then the delta Z, which is the elevation data over an 8 mm diameter of anterior and posterior surfaces. The best fit sphere is a toric best fit sphere. In that, the highest point is KVF and KVB. So now whenever you read Sirius reports, try to understand this. What is SIF, SIB? What is KVF, KVB? And third is Biocchi-Kelossi-Versassi index, which is a sum of the aberrations which are most common in keratoconus, which is coma and trefoil. Then the last comes RMS by A, which is a deviation in the regularity or aberrations of the corneal surface. So yeah, so deviation, so the irregularity or the aberrations, that sum is RMS by area, which is a very important thing for diagnosis of subclinical keratoconus. So this is how the keratoconus summary comes on the system. And as we can see, there is a class here, which is normal. And it could be other classes. It could be abnormal, treated means post LASIK or post PRK, and this is suspect keratoconus and keratoconus. Actually, we see on the system, these are the maps that come in the keratoconus summary: tangential maps, elevation maps, relative pachymetry, and Placido rings. Now, how does the system analyze if it is a normal, abnormal, suspect, or keratoconus? There's a comparison, there's an artificial intelligence in the system which compares it with a huge population of data, and that's how it gets it. Now, very important that does Sirius has a good sensitivity with diagnosing subclinical keratoconus, and with the current studies, this is a 2021 study, and it's really good. And with most of the studies that we have read, it is highly sensitive, and it is equivalent to pentacam. Also, there are maybe few areas where it could be better than pentacam. So this is also, there's a keratoconus follow-up option also, where you can help understand the change in the keratometry, the thinnest corneal thickness, and the elevation over the visits. This is important to see the changes pre and post C3R, or pre C3R, to see if there is a progression. Very easy to analyze it in this way. If you go to the system and check for the same patient at different visits, and the differences between Sirius and pentacam is only based on Scheimpflug, and Sirius is based on both. And yes, maybe Sirius has better anterior surface parameters because of Placido incorporation. Other than that, the parameters with the best area under the curve to differentiate between subclinical keratoconus from normal eyes are BAD D on Pentacam, SRI on Galili, and 8 mm RMS by A back on Sirius. CCT, yeah. So if should also try to now analyze CCT that you see on different systems. We have got OCT, PACI, and Sirius, and in both OCT, PACI is always around 10 microns lesser than Sirius. More or less, that will be lesser than the ultrasound PACI that we take. So that's how it goes. Ultrasound PACI, then Pentacam, then Sirius, and then OCT. And the repeatability of the CCT is very, very good. Yeah, this is how. So we can see in the study that the ultrasound PACI is 535, Lenstar is 532, Sirius is lesser, 526. RTV OCT is actually here around equal to Sirius, but different studies are showing, and with the limited experience that we have seen, it's almost 10 microns lesser. Keratoconus patients show varied pachymetry. The CCT of both the devices might not correlate. Yeah, repeatabilities of Pentacam and Sirius. So in various visits, the CCT was found to be similar. Now this is the repeatability estimates. In that, see, the CCT when taken with a Sirius at different visits is only different by 7 microns, whereas with Pentacam it is about 11 to 12 microns. So in between two visits, if you find a difference of 7 to 10 microns in Sirius, that is okay. It is just because it's a different visit that we are seeing. And similarly for steep K and flat K, it is around this much. Okay, so I think we are done with the most of the theoretical part. Now I would like the fellows, even the recent fellows who have joined for refractive, to tell us about little bit about these maps. It's a very basic map. We can just discuss, no pressure. Who is there?
Nitish?
Nitish, this is like Tommy only.
Yes, ma'am. So, ma'am, there is no classical imaging is there. So, first map, I think the image is not very clear, but keratometric data might be there, and in the center there might be KMX value should be there.
Yeah. So
As
what is this map? This is the, what is this map? You're not able to read it. This is the corneal thickness. Okay. So
cornea thickness map.
yeah, what is this map? What kind of map is it? Is it an elevation map? Is it a curvatural map? Is it a pachymetric map?
Ma'am, keratometric data are there. So,
Right. So
central anterior view
yeah, so it
curvatural
is,
map.
yeah, it's a curvatural map. And what is this? This is an elevation map. Okay. Now, so
Okay.
what I need you to understand is this is a hot color, no? That means that the cornea is steep in this area and in this area. And correspondingly,
Ma'am, we are
when we
not
see the
getting a very good audio input
elevation
from your side.
data,
Ma'am, can you please repeat, ma'am? Audio was not very good.
here it is. So where the curvature maps are showing hot colors, right? Are you able to hear me now?
Yes, ma'am. Yes, ma'am.
Okay, okay. So there the elevation maps are cooler. It's blue, right? Hello?
Yes, ma'am. Yes, ma'am.
Yeah, so this is not
Dr. Arushi, your
now
voice,
Nitish,
Ma'am,
can you
we are not able to hear you properly.
आपका voice break.
okay, तो डॉक्टर कौशिक पूरे इसमें सुनाई दे रहा था क्या?
नहीं नहीं, एक बार पूरा रिपीट कर लो प्लीज। पूरा इसमें सुनाई दे रहा था, एक बार जो आप बोल रहे थे एक बार रिपीट कर लो प्लीज।
अभी का ना जो मैप्स का बता रही हूँ
मैम,
ना।
यस मैम, लास्ट मैप का था जब आप बोल रहे थे मैम, तो वी आर नॉट एबल टू हियर।
अच्छा, अभी आ रही है आवाज?
यस मैम, अभी बहुत
अच्छा,
सही से आ रही।
तो अभी ये जो है कर्वेचरल मैप है, उसमें जो ऑरेंज कलर है दैट इज अ हॉट कलर, राइट?
यस मैम।
And this is a blue is a cold color. So cold means that the elevation is not there in this patient in this area. So this area is corresponding to this area. That means that this map is a regular astigmatism. It does not have ectasia. Ectasia means does not have keratoconus or any kind of other ectasia. Okay. Now, when we come here, what is this? Is it hot or is it cold?
मैम, हॉट एरिया,
In
येलो इज
yellow is hot.
हॉट हॉट हॉट।
So yeah, there are colors. There's a map in which all the yellows and the reds are hot, and the greens and the blues are cold. So where the elevation maps are showing yellow, what are the where the curvature maps are showing yellow? What are the elevation maps showing?
रेड।
Yeah, so
सो
that means that this area is corresponding to this area. What does that mean? That it is a ectasia. Okay.
यस मैम।
Yeah. So sometimes when it is very advanced, you will also see that the corneal thickness here also has a red. And that is also corresponding to this. And sometimes when it is even more severe, even the anterior elevation maps will see a red here. Okay. Okay. So again, here another case of similar. You can see the red, and you can see the red, and you can see the red, and you can see the red. Okay. So this is like a frank keratoconus. Uh, yeah, again, Shrishti, anything?
467 is the corneal thickness, so it is bit on a lesser side. There's thinning. The cooler colors are seen on the anterior sagittal map, and it is horizontally, not vertically. So it's and
क्या
these are
पूछना है क्या सृष्टि इसमें?
yes, sir.
इसमें कोई स्पेसिफिक चीज पूछना है किसी को?
कि पोस्ट पहले कभी कोई सर्जरी तो नहीं हुई है, रिफ्रैक्टिव पोस्ट रिफ्रैक्टिव सर्जरी ऐसे में?
Yeah, it's a post-refractive surgery map. But yeah, I also don't know the exact case. I've forgotten the case, but yeah, it's a post-refractive surgery map. And but yeah, what this thing is it hot or is it cold?
Cooler colors.
Yeah, but it is hotter than this, no?
Hmm.
So that corresponds to
Ventral
this blue.
flattening and peripheral थोड़ा सा steepening.
Steepening. तो वो जो steepening जितना भी है वहां पे cool है. What I'm just trying to make you guys understand is a point that you should try to see in every patient now, because this kind of thing is what you will in the beginning of ectasias, it is easy to understand, then diagnose early ectasias. Okay. Okay. Now again, Shrishti, what is this? On the curvatural map, what can you see?
So it is asymmetrical bow tie with skewing of axis. So the superior is steeper than the inferior. So
can you see anything on the elevation corresponding to that?
Elevation has flattening over there, and the inferior a bit warmer color. So
yes, true. So yeah, so similar kind of picture in the other eye. Now, what could be the reason of only an anterior surface steepening without anything else? And that too superiorly on the cornea.
Terian's marginal degeneration.
Yeah, it could be Terriens, it could be multiple things. But yeah, this case had LSCD because of and pannus and scars because of various things. So we actually had to plan refractive surgery for this patient. He was a contact lens user, and we had planned PRK, and patient is doing well. Yeah, this is a suspect keratoconus. Again, suspect keratoconus. Okay, this patient came to us in the keratometry. Can you see any difference in the AR?
Yes, ma'am. Left
Yeah.
side keratometries are there steeper.
Yeah, so this was a 29-year-old male who came to us with only trying to who had got glasses only for the last 3 years, and he had mild ocular pain and this kind of keratometric difference. What we are always seeing is scissoring. So I have a habit of doing retino in all patients that I feel that might have keratoconus, and it is extremely rewarding because that is one thing that you can do even if you don't have anything else. And this kind of patients, I think, so he turned, I'll just let you know. So this is what we had on the Sirius. The Sirius was breaking up due to some reason. And on repeated with lubricants also. Does anyone have this kind of a situation ever?
Yes, ma'am.
Oh, then what do you do?
I think we put the lubricating drops and then again repeat the series.
Okay, so I don't know what happened. It was not happening. But the question was this patient had a left eye frank keratoconus and right eye was right eye. There was a query whether patient has a keratoconus, and we were planning left eye CXL and right eye we didn't know. So we needed a report because the report was actually showing not enough data to classify. And so we had a pentacam done, and the bad maps did not show anything in the right eye. And there was, so right eye was told to follow up, and left eye was told
In right eye. So it's
sorry?
the D value is already 2. So he's already keratoconus suspect in the right eye, and left eye is frank keratoconus.
Yeah, true. So it's a keratoconus suspect. I wouldn't label this. It would be labeled as a abnormal cornea to be followed up.
Okay.
Keratoconus suspect would be something that would be coming frankly on these maps. Okay. This so when the D values we see, these are based on various values, and what we can do is repeat the maps maybe after 3 months and then conclude anything, especially even supposing if this kind of patient has to be planned for refractive surgery, and you are seeing that this is normal and this is abnormal, and would you plan a refractive surgery? We don't know, right? So we can't label it as keratoconus suspect, but yes, we need to repeat the test, reassess, and then plan.
Okay.
This patient also, this is my friend's data, and this was a pentacam. Yeah, I think, yeah. So this pentacam showed abnormality in the right eye posterior elevation. Uh, but the Sirius did not show that there was any abnormality. It was a normal cornea. Now, this patient did undergo refractive surgery. So what you can see here is that the corneal diameter is 10.7. So when the corneal diameter is very less, certain posterior elevation factors might come positive, especially in pentacam and even in Sirius. But at that time, we repeated Sirius, and this is what we got, and it was a normal cornea, and the patient went ahead with refractive surgery after repeated tests over 3 months. So yes, corneal diameter does affect indices related to back elevation and pachymetric progression. This is discussion that is Sirius topography and accurate machine. Yes, it is according to various studies and also some experience from some surgeons who have shared it. And CCT is very much reliable, and there might be a query benefit of Cirrus over Pentacam that it has a better anterior surface data. And to all the surgeons that I have spoken about, they are very much satisfied with Sirius. Yeah, so I think we can stop it here. We can, any questions you guys have?
आरुषि एक बार जो ये है ना, प्लीज शो अस द लाइक पैरामीटर्स व्हिच आर शोन इन द प्रिंट आउट लास्ट में। हाँ, उसमें जो केवीए या जो भी है ना, उसमें क्या क्या हमें कुछ याद रखना है क्या? एक्चुअली व्हाट आई डू इज आई सी द लास्ट इंप्रेशन की नॉर्मल है कि क्या है, बट इज देयर एनीथिंग व्हिच आई शुड लुक लाइक अराउंड 4 or 5 things which I should look and which will give me an idea whether what is
This is, can you see this, sir?
yes.
So this is what in the keratoconus screening is generally what we see is the class. Now, as we see here, we can see that there is SIF and KVF and BCV, which we understood what it is. SIB, KVB, and BCV, and this is the thinnest pachy. Now, these factors can be seen and analyzed at various visits, but supposing why do you want to see? Supposing we need to see if there is a progression or not, then over multiple visits, these factors are analyzed over 2 visits and it can be seen. But more or less, this class comes out from the system only, and this can be relied on whether it is a normal or an abnormal cornea. Except that the indices that have to be seen are on the Kmax, which is here, which is and the thinnest pachy, which is here, which have to be seen over various visits, and the simulated K, which is K1N. So many of the topographers have, while giving the printouts, they have a option of including the simulated K or not. So go and check if it is there in your printout, but sometimes it is not there. So we added it and now it's coming. This is what is important. Rest of the factors, we do not know the cutoffs. We do not know for sure. There's no study which is for sure telling that this is the cutoff. So we rely on the machine's output of whether it is normal or abnormal.
What is the value for CCT? जैसे यहाँ पे जो है, तो what I have seen that ये CCT जो anterior chamber में जो anterior chamber depth जहाँ पे कैलकुलेशन हो रहा है CCT plus AD, वहाँ पे CCT एक लिखा रहता है। ये जो लास्ट में केराटोकोनस स्क्रीनिंग है उसमें थिकनेस और एक लिखा रहता है।
सर
तो
ये हाँ, ये जो है हाँ सॉरी,
हाँ,
तो ये थिनेस्ट लोकेशन इधर आ रहा है, दिस इज 533, और ये सीसीटी मतलब सेंट्रल कॉर्नियल थिकनेस। तो सेंटर ऑफ द कॉर्निया का जो थिकनेस है वो 534 है। तो कभी कभी केटोकोनस में थिनेस्ट और कम हो जाता है, जैसे 4 मे बी 500 होगा और सीसीटी माइट बी 534। तो यहाँ पे जो आएगा वो थिनेस्ट आएगा।
अच्छा, thinnest thickness वहाँ पे लिखा है।
यस यस।
And is there any like cutoffs for anterior like anterior elevation and posterior elevation in Syria? जैसे पेंटाग्राम में कुछ cutoffs है ना, जो आपका फ्रैंक केराटोकोनस के लिए कुछ cutoffs हैं।
हाँ, सो पेंटाकैम में है, इसमें बहुत क्लियरली नहीं है, बट KVF एंड KVB 7 माइक्रॉन्स एंड 12 माइक्रॉन्स, ये एक रैंडम है एक्चुअली। क्या हो रहा है कि हर मशीन जो आ रही है वो पॉपुलेशन डेटा चेंज कर रही है, तो उसके हिसाब से ये KVF और KVB के जो कट ऑफ्स हैं ये सब भी चेंज हो जाते हैं, और वो मशीन जो फाइनली कैलकुलेट करता है वो उसके करंट डेटा के हिसाब से करता है। तो बेटर इज टू रिलाई ऑन द मशीन्स आउटपुट देन नोइंग, बट एक एवरेज ये है।
Hi, sir. Hi, ma'am. Just wanted to add, there are a few, just a ma'am ने भी कहा, there are not very clear guidelines, but थोड़े rough cutoffs हैं in some areas that most of us use. So what happens in normal practice is that many a times a patient comes with pentacam from elsewhere or Sirius from elsewhere, and we have to see कि okay क्या हो रहा है, like what is the follow-up like. So I would just, ma'am, if you could just show me that map जिसमें the 5 columns are there. So I use it exactly like Pentacam with a few rough guidelines that I learned from my
Yeah, which
colleagues
one
and
are you
seniors.
speaking about?
The one that we were just talking about, the one with 5 columns, the summary indices.
Okay.
Yeah, so as ma'am already wonderfully mentioned, first we see the quad maps and just check out for the hot on hot areas. On this summary indices, the extreme left, the 2 most important values to check out is Kmax, as ma'am already mentioned, and the thinnest patty. Just like Pentacam, Kmax ka bhi same cutoff we use 47. Of course, these are rough guidelines because dono ka algorithm different hai. So it has been found that 0.7 diopters का difference and 10 microns का difference Pentacam and Sirius में आता है. So Kmax nearly the same. Thinnest Pachy also nearly 480 as the cutoff, and the y-axis of the Pachy or the temporalization of the Pachy point, we can again, as ma'am described, we can check out from the Cartesian coordinate. Then the second column where we have the K readings, many a times this also you can go for a hemi-meridian kind of format, wherein you will get 2 K1s and 2 K2s. So hemi-meridian means the upper half, lower half, temporal and nasal side. So this we generally use to check for skewing. You can very easily calculate K1, K2 skewing if you have 4 different axes. So if this is more than 22, you can make use of the second column. The third is the posterior surface and the K reading. Then in the shape indices, what was found out was that over time we realized that we already know that ectasia starts from the posterior surface. So once that ectasia starts from the posterior surface, a coma, trefoil or spherical aberration, these are the first aberrations to start from that area. So we pick up the same RMS value that we use in an aberrometer. So RMS or root mean square value is the value that we use in aberrometer, and root mean square per area is used here. So a rough cutoff for the front and the back is that root mean square for the front, be it for 4.5 mm pupil or 8 mm pupil, we generally use as 0.08. As in it should be lesser than 0.08. And root mean square for the back, both for 4.5 and 8 mm, it should be lesser than 0.2. If I compare it with Pentacam, so Pentacam में हमने thinnest Pachy देख लिया, temporalization of the pachymetry देख लिया, Kmax देख लिया, and then we have anterior and posterior elevation points, which already we mentioned. Just like in Pentacam, we have 12 and 17 for anterior and posterior elevation point. Here we have 7 and 12, which is a rough guideline. So that KVF and KVB is given on the extreme right value side. Can you see? This KVF should be less than 7 and KVB should be less than 12. So here a bit of posterior ectasia is starting according to this. SIF and SIB is similar to the inferior-superior asymmetry of the Pentacam. So just like how in Pentacam between the 3 to 5 mm zones, the inferior minus superior should be less than 1.5 diopters. Similarly, SIF and SIB, if it is a positive value, it means that there is extreme inferior superior asymmetry. That is, inferior is much, much steeper than the superior one. So the cutoff of SIF arbitrarily, it should be a positive. If once it is a positive value, it means it is steeper. So it should be less than 0.7. So here we see that the front, the anterior surface is steeper. SIB again, if it is a positive value, it means that the back surface is also, the inferior part is steeper. So SIB, the cutoff is 0.2. So roughly this applies, I mean, it shows as normal, but it does have a few posterior float points in this particular curvatural map. Similarly, this entire machine algorithm, what they found out was that RMSB, as in the root mean square value, was the most sensitive and the first value that started changing when we got patients who came up just with initial posterior ectasia. So they came up with their own equation known as BCV. BCV front and back is a very, very standard equation, be it BCV front, BCV back, or BCV front over back, a proportion of these two. This should be less than 0.8, and BCV front by back, as ma'am already mentioned, has been compared to bad. So if you see that BCV front and back in this keratoconus screening is less than 0.8, it means that the bad maps might actually be green in this patient. So finally, that is why the class has come out to be normal in this particular graph. So these are the things that you can compare in a very, very similar way to a keratoconus patient. And as ma'am already mentioned, delta Z, which is an approximate indication, there is no cutoff for delta Z at all that you see in the quad maps of Sirius. That varies a lot. Even on repeatability scans, delta Z has a very, very variable value. So we don't stick to any arbitrary cutoff also in those points. I hope that helped. Anything else that, like, these are the daily, because it's difficult to read with so much of clutter. So these are the 5-6 important parameters of pentacam, and we use the same parameters with different standard values in Sirius, so that we are able to see and compare a pentacam map and a Sirius map of a patient, like in a similar time scale or a similar time period. Thank you.
Yeah, thank you so much. That was very, very nice. Can you have you seen any more differences between pentacam and Sirius? What are your conclusions, like for the same patient in a
Yes, ma'am.
yeah.
So repeatability wise, like if I have a pentacam at my place and the same patient on the same day ends up getting a Sirius scan. So this is the part of multiple studies also, that repeatability wise or comparison wise, both are not very similar. Like the Kmax and the dioptric values have a difference of roughly 0.7, and the pachymetric values have roughly a difference of 10 to 12 microns. So that is there, but apart from that, it is quite comparable. As in, if you just ignore a 10 micron here and there and a 0.5 to 0.7 diopter here and there, they are very comparable. But a serial comparison, as in comparing a Sirius map of 2 years back with a pentacam map of today, I wouldn't suggest that, because that difference, that time gap makes the difference even more stark. As in, if there's a change, ongoing change in the patient over the last 2 years, so then you cannot compare it serially with a pentacam map.
Right, I think so. We cannot compare two different machines. That's
True,
what.
true.
And another thing, supposing there is a patient you want to take for refractive surgery, and the Sirius is showing that the patient there's an abnormal cornea. Would you repeat a pentacam, and do you see any difference in that?
I have definitely found pentacam repeatability as well as pentacam reliability to be much, much more better. Somehow, many a times in abnormal cornea, the Sirius just ends up giving us something like data unclassified or abnormal, or the class finally does not leave you with a comment in the end. In that case, the reliability and repeatability in pentacam has been to the point very accurate over time and again. So I would definitely vouch for a pentacam, but in case there is a Sirius, we have to make do with it. And it is actually a wonderful machine. It is very intelligent. There are many advanced data, but they have just made it very complicated. So to learn so many cutoffs for so many different values is difficult. And that is why I just stick to this one standard KVS, KVB, BCV, the cutoff being 0.8, the PACI, the Kmax skewing, and SIF and SIB being a positive value. These are the only 6 basic things, and these are actually the 6 basic foundation stones of pentacam as well. And just correlating with this with a quad map, it makes me 100% certain that I'm on the right track.
Thank you, ma'am.
Hi, I have one question. Like the screen that is being shown here, although the Sirius is showing it to be a normal class, but just now it's being discussed that there's some few points of like posterior abnormalities and all. So in such cases, what should we do? I mean, should we proceed in this case for refractive surgery, or should we repeat the pentacam and see?
Yeah, so I think I would proceed, because I do not rely on the individual cutoffs, but yeah, even
exactly. Yeah.
yeah,
Even I would proceed with this particular case, because the SIF, KVF, SIB, and KVB cutoffs are an approximate value. Whereas the BCV is, as I mentioned, that is the most standard value on the basis of which Sirius algorithm also works. So the BCV is very much within limits here. It is much, much lesser than 0.8, and that is why the class has also come out to be normal. Other than those, there are no other, like, red flag areas with Kmax or temporalization of Paki. There is no skewing. Even RMS is completely normal. So anyways, these cutoffs that I mentioned, the other ones are a rough guideline. So it could just, like, signify some arbitrary elevation point and not an entire ectatic cornea. So I will also go ahead in this case.
Thank you. Thanks a lot.
Any more comments by anyone? So we can stop, sir.
Dr. Arushi, thank you. This was an excellent presentation and discussion was also good. I think if there are no more questions, I think we can close.
Yes, okay. Thank you so much. Thank you all fellows and Dr. Devika, everyone, Dr. Kaushik, thank you so much.
Thank you.